So I welcome you, Karen, to this interview, which will be shown at the webinar on 10th of June for lipedema patients and other people in Sweden. And you have been in Sweden many, many times.
Yes.
With us also. And it's very nice that you actually can take your time to do this with us now. And I would like you to introduce yourself, and we will go on from there.
Sure. Hi, everybody. My name is Dr. Karen Herbst, and I am a board certified endocrinologist in the US. And I have a very special interest in lipedema, have since the beginning of 2006. So I've been doing this for 15 years or more. And I retired from the University of Arizona in February of 2020, right before the pandemic. And I'm currently in private practice at Total Lipedema Care, where we're taking care of patients, but also very interested in continuing research on lipedema in our practice. I'm also of the Standard of Care Committee for Lipedema in the US, and an NIH sponsored grant from HLBI to have a meeting and come together to form a consensus so that we could write up guidelines for lipedema in the United States. And I am excited to say that we are now published with our very first publication that I hold in my hand.
That's fantastic, Karen. So for how long have you been working with this standard of care document? And how many others are in the group?
So there are 21 people in our group. We met in 2008. We met in 2000 at the Fat Disorders Resource Society conference. And we followed, standard guidelines. We wanted that we rated what we were saying, because even though there are more and more publications coming out on lipedema, there aren't enough in order to properly grade recommendations that you make. Usually when you make a recommendation, it's based on a large randomized controlled trial of a specific treatment or a medication, and there just aren't enough for lipedema. But we went ahead and graded things so that we could give people an idea of how we truly felt about the recommendations. So we have 85 statements, and based on each of those statements, they're all graded and they're all supported by evidence to the best of our ability or our expert opinion.
So this covers diagnosis as well?
Yep. So we start out talking about the pathophysiology of lipedema. And I know there's a lot going on in the field right now trying to figure this out. And by definition, fat tissue on the body is loose connective tissue. And so for the first time, we define lipedema as a loose connective tissue disease. And we think that's very important because it's not just fat cells. In loose connective tissue, you have, in addition to the fat cells, you have blood vessels, both arterial and venous. You have the lymphatic system, you have immune cells, and you have a structure to the tissue that includes collagen fibers, elastin fibers, but also fluid. And that fluid is either present as a gel, so you've got water and salt bound up to these structures called proteoglycans, or you have liquid, and it's in balance. And what we think is happening in lipedema is that the balance has shifted more towards the gel, and that gel makes it hard for fluid to the tissue. And then we go on to actually describe how to diagnose lipedema, and we base this on our expertise, but also on the standard of cares that have been published by other companies or countries, including the UK, Germany, and others.
Oh, that's good. So that will help. I mean, Sweden they have no recommendations or guidelines for lipedema. So that could actually help Sweden to form some kind of statement on how to diagnose. and to train doctors and lymph therapists to actually be able to diagnose lipedema as well.
Correct.
Oh,
Yeah, I mean, I think it's really important to differentiate lipedema from people who have non-lipedema obesity or people who have non-lipedema lymphedema. And there is overlap in all of them. It's women with lipedema and men are at high risk of developing obesity. And that's something we need to prevent. And we can't prevent something that we're unable to diagnose.
No. So what do you think are the most important factors for people who do not receive any kind of care at all? Is it compression, or is it psychosocial support, or what do the standard of care mention foremost?
So we talk about both of those. We think compression is very important, and we actually have a table about compression, and that's how important we think it is. You reserve your figures and tables and a paper for something you really want people to take home with them. And we felt so strongly about compression that we made a table on it. And for lipedema, we don't think the compression has to be, super, super high. And in fact, it's difficult for patients with lipedema to wear really high level compression because they have a lot of pain. And in fact, there's a recent paper out by Angst et al. Showing that women with lipedema have much more pain than patients with lymphedema. But again, we still think compression is important to reduce the pain, to reduce edema tissue, and to just support all that loose connective tissue, especially if a person has lobules. And then we also think that psychosocial care is very important. We need to recognize that a lot of people with lipedema have depression, have anxiety. And Joanna Dudek showed this very well, that there are so many symptoms of lipedema that can lead to depression, and that definitely decreases quality of life for people living with lipedema.
Yeah, and we see that people have this anxiety and no what's it called? Self-respect,
Self-worth, yeah.
Yeah, and of course, if you don't have that, it's very, very difficult to do anything at all. You need to be coached by somebody who knows about the problem or understands the problem, I presume.
I agree. Yep,
So,
I think it's very difficult to start taking care of yourself at home if you don't even have a diagnosis. So a diagnosis is so important. And then I think there's multiple factors that feed into that depression and anxiety. For example, a lot of women, at least in the United States, who have lipedema also have hypermobile joints, and anxiety is directly linked to hypermobile joints. So not only do you have anxiety and perhaps depression because of being undiagnosed for years, being told you're just fat and that you need to diet and exercise, but that's all you do is diet and exercise and still nothing happens. Then you add in the anxiety from the hypermobile joints, and that leaves a person questioning, their own self-worth and, their place in society.
Yeah, yes. And what about other recommendations in the standard of care document? Do you have anything about nutrition and food?
We do. Obviously we're restricted in length in terms of the document, so we can't talk a lot about it, but we recommend a healthy diet for everybody. We recommend that the processed carbohydrates are kept to a lower level so that insulin levels don't rise. Insulin levels rise when you eat sugar, and insulin makes fat grow. So we felt that it was important to at least state that food plans did not raise insulin levels. And I think it's important to maintain weight in lipedema and not to progress on to develop obesity at the same time. So we do mention nutrition, and we also have a nutrition book out on lipedema and lipedema. So we did reference that. And then the other, we talk about so many things, but some of the other things that we felt were very important included Venous disease. And venous disease hasn't been talked a lot in association with lipedema. If you look at the Wold, Allen, and Hines paper, which is the second paper out of the Mayo Clinic group, they report that about 25% of women with lipedema have venous disease. And then there's another paper that came out of Austria saying the same thing. And then Steve Dean recently reported that 50% of women with lipedema and lipolymphedema, so they've gone on to develop lymphedema, have significant venous disease. So that's a lot, but there are no recommendations at all. And so we actually discuss that in detail.
So that means that a large portion of lipedema patients also have venous edema, venous problems.
Correct, correct.
So
and we need more research into that, though. There's almost none. But I think what our paper does is it puts it in the limelight and says, hey, we need more work in this specific area, because we know that venous disease, especially venous insufficiency, is one of the leading causes of lymphedema.
Yeah, yes. We are just discussing in Sweden about the fact that the Swedish healthcare system is very ignorant in putting the codes for various diseases and diagnoses in the registers. So we found out that very few have lipedema in Sweden, because you can't see, they only say lipedema without the code, the ICD code. And I presume it's the same with lipedema with venous diseases as well. So they should actually have 2 or 3 codes, because they may have lymphedema as well.
Yeah, I think it's, I think we have to be very careful to not pile everything into the lipedema bucket. I think that there's not just going to be one gene for lipedema and then, yay, we're all done. I think there's different ways to develop legs and arms that look like lipedema, and venous disease is a big contributor. There's so many people who have venous disease in the world, there's millions, but I think when you combine that with the genes that are important in lipedema, it just makes everything worse. There's so many things that can make lipedema worse that involve inflammation. So a lot of women with lipedema have allergies, like allergies to multiple medications and multiple plants in the environment, or animal hair and fur, and these all add up. You add in the inflammation from venous, add in the inflammation from allergies, it all promotes the progression of lipedema. And these are all things that we have to consider. Just say, oh, look, there's a woman with lipedema, and you don't realize she also may have some obesity. She also may have some venous disease. She also may have allergies. I think we're not doing her a favor. So it really takes an astute primary care physician, really, to put this all together and to care for all the diseases, to improve her quality of life and to prevent her from progressing.
It's complicated, really.
It's complicated.
In this standard of care document, have you any kind of recommendations for liposuction at any stage, or have you left it out?
Nope, we do recommend liposuction, but what we're calling it is lipedema reduction surgery, because it's more complicated than just liposuction. Liposuction is generally considered to be cosmetic, but lipedema fat is unique in that it's very difficult to lose by exercise or even bariatric surgery. So removing it by surgery is one of the only means to get rid of this very fibrotic tissue. And I'm amazed liposuction, it's very difficult for them to sometimes remove anything because it's so fibrotic. So when we talk about lipedema reduction surgery, we're also talking about, for example, removing the belly. Sometimes women with lipedema can develop a very large panniculus that hangs down, is very heavy. It presses on her legs when she sits. That has to be considered. And also, if a woman has progressed in terms of lipedema, once you remove the fat tissue, she has a lot of excess skin. So that needs to be addressed too. So it's a comprehensive discussion of the surgical recommendations. And I think, and basically we say that you need to take into consideration each person as an individual. A woman with stage 1 lipedema can have a lot of pain, and lipedema reduction surgery reduces that pain for up to 12 years. At least that's what the studies show out of Germany. So I think it doesn't matter the stage, it matters the person and what, in terms of conservative therapy and what they're still suffering with, especially pain, mobility issues, obesity, and very heavy tissue.
So that's very interesting. And will this standard of care be spread? How will it be spread and used in the States?
So we have our American Vein and Lymphatic Society meeting this October, and we are going to present there. And as I mentioned, this paper was a true consensus. Everybody participated in writing this paper. Everybody agreed on what was written. And I know all of my co-authors are planning events to spread the word on this paper. We also paid for it to be open access. We didn't want people to have to pay to get this paper, so we paid for everybody to have access to it. And we also have a number of other affiliations that are going to help us spread the word about this paper.
So it will be used and people will actually be able to get some kind of help using this document.
Yes, I think it's really helpful for healthcare providers to use as a reference. So, for example, there's a debate whether there is actually lipedema tissue on the abdomen, but we're very firm in saying, yes, lipedema tissue can occur on the abdomen. And we have a lot of supporters all over the world who also are in agreement with that. But there's some people that deny the existence of lipedema tissue on the abdomen. So we felt it was really important to say that. So when providers pick this up and they say, I wonder if that's lipedema tissue on my patient's abdomen, they can say, oh, look these people all believe that to be true. So I'm right. There is lipedema tissue on the abdomen, and then they can go ahead and try to help that person reduce it in whatever means they're using to do that. But if we didn't say that, then they wouldn't even look at the abdomen. They would just look at the legs. They would just look at the arms. So I think it is a very good guide. And we have very, very good authors who are very well respected. So when they see these authors, they'll know, aha, I know that person and I believe what they're saying.
So that is very good. And then from the Swedish point of view, will this document and other documents have been published, because now it's so many documents have been published in England, in Germany, in other countries, I think Spain and Italy as well.
Spain, Netherlands, yep.
Yeah, but Sweden has not taken those documents. They want to do their own research, and as there is no care, you can't do any research. Even if you can't diagnose, you can't do any research either. So with all these documents, we may push to the politicians to actually help these people, because they are really suffering very badly. And today they don't even get compression only in one region. They are paid by the public finance with compression. Others, no care, no compression.
Yeah, I think that at a bare minimum, you have to provide compression, because it's so supportive. It can reduce pain. It really helps people make it through their day. If they don't have compression, their legs will swell by the end of the day, and then their work day diminishes, their ability to work diminishes. And these are people who want to participate in society. They want to participate in the lives of their family. They want to live. And just compression alone is a really good start. I also think compression pumps are very helpful, because not everybody can go to a therapist, hands-on therapy every day. It's just not going to happen. And so people need to be educated by therapists to take care of themselves at home. But I think compression pumps also provide a way to empower these people to take care of themselves at home. So we need to really support people to take care of themselves. That's our goal, but you can't not give them to do that.
No, you need to coach them and to teach them how to do it.
You do.
What about self-care? Do you have self-care in this document as well?
We do talk about self-care, and we also talk about caregivers as well. So I think when a person has lipedema, it's really nice if they do have another family member or a friend that can help them care for themselves, whether helping them get their pump on or off, or supporting them as they go to their appointments, to reassure healthcare providers that yes, my family member is eating very well, she's exercising a lot, and still nothing's happening. Please help my family member.
Last question. What about exercise? Which is the best exercise that we can promote to all the lipedema patients in Sweden?
So I think any exercise is the best exercise. But, the things that are really easy to do are walking, and walk, especially with the Nordic poles. I'm all for that. I think when you use poles, you're actually exercising your arms and not just your legs. But I think it's really important to wear compression when you walk, because exercise generates lactic acid. Lactic acid can contribute to inflammation. And the compression garments also support the legs so that they move easily past each other, because there's so much lipedema tissue on the legs. If the legs are rubbing against each other, the body starts to shift and weigh as joints. And so wearing compression while walking is I would say my number one, and that's the easiest, but number two would be anything in water. It's really great for lipedema tissue.
Thank you very much, Karen, for taking your time to this. And we'll see you soon also after
Thank you so much. Thank you. I hope to see you soon.
Me too. Bye.
Take care. Bye-bye.